Okay, so my name is Bleddyn Rees. I am the Deputy Chair of the ECHAlliance and the Chair of the Digital Health Society. And unlike American tradition, when you introduce doctors and it seems to take 10 minutes to read their CV, mine is really simple. I'm an international healthcare lawyer. That's all you need to know. I won't bore you anymore, except to say that unlike American lawyers, UK lawyers tend to be good guys. So I'd like you to know I'm a good guy, okay? Right, so thank you very much for all coming. We're delighted to have you here. Some housekeeping. Sheila, the lady who has the Union Jack bucket hat you see in front of you, is going to walk around the room, and those of you who are interested in what we do, I'd like you to put your business card in the hat so that we know who attended and we can reach out to you afterwards. Old school style, but hey, why not? Okay, so a couple of things to say. You should have on your tables and on your chairs a leaflet with the running order of today and a little bit about us. At the end of the 3 sessions, and I should be using the slides, sorry. That's who I am. So that's the agenda. We're not actually fielding in exactly the same order, but we are covering all of the topics. So what we will do at the end is have a Q&A, allow you to discuss and talk to us. We absolutely would like to have questions, so please feel free to do that. We are a membership organization, so the plug is, if you like what we're doing, if you have solutions to bring to some of our communities, tell you a little bit more about that later, please talk to us, join us. We are a not-for-profit organization to start with. So this is who we are, and we have, as you can see on the slide, some 80 geographic ecosystems. I'll explain what this is in the following slide. So we're working globally, and we do basically 4 things. We connect people and organizations, we convene meetings, roundtables, and we amplify messages, and then we accelerate the work of our members and our communities. So a little bit more, this is perhaps the key diagram for you to understand. 12 years ago when we started, we came up with the idea of an ecosystem. Nobody had heard of the word at the time. They had to go to the dictionary. Nowadays, everybody's using the word, but they are using it in very different ways. For us, this is a community. And on that wheel, you will see all of the stakeholders needed to transform health and care. So you have the traditional health as an industry, domiciliary care, care homes, but then you start to see industries that you would expect to see there, like tech, med tech, pharma. But we bring industries that nobody knows are involved in healthcare necessarily. So automotive, energy and maritime, and I'll say a little bit about that in a few minutes. So we then have education sector, housing, and not-for-profits, so typical anything from a 2-person drug counseling service to a national charity to an international charity. So that's the heart of what we're doing, and we're breaking down silos. We are transferring best practices from one place to another overnight, and failure. So if somebody's tried to do something and it hasn't worked, we believe that's just as important for people to understand and be aware of. And part of what we're trying to do is to persuade governments to stop seeing healthcare as an expenditure and see it as an investment in the health of their citizens and in investing in their economy to grow jobs, grow GDP. We call that the health and prosperity agenda. So this is what the international ecosystems look like, the 80 around the world. So North America, South America, Europe, the Far East, Africa, India. And what we like to say is that no country has a monopoly of good ideas, and we are always finding innovation in sometimes the most unlikely places. So our network is about finding this innovation and transferring it across borders. So here are some of our US members, and I'm not going to talk about them. You're going to recognize, I'm pretty sure, the logos from these organizations. But I talked to you a little bit more about bringing innovation from other industries. So this is a conference in Barcelona, the world's largest telecoms conference. If you can see the slide, 2014. Okay, the industry that knows the most about remote monitoring of healthcare is not health. It is, in fact, energy. You might wonder why, because energy owns the most number of ships in the world, and people have been getting ill on ships for centuries. They were the first users of telecare. Energy companies are very data-centric. They don't drill anywhere unless they have data. That's why they are pioneers in the use of health data and remote monitoring. Another example from 2015, this is Barcelona Football Club, but it's actually 9 professional sports. They have a whole innovation ecosystem built around the football club. So this is another example of where we can take innovation and approaches and then try to scale it. Another one, I'm Welsh, this is the Welsh Rugby Union, and they like to say that they're in schools but not in tracksuits. What they started to do was to create a digital curricula for nutrition, exercise for school children. So another example of how sports clubs can make a big contribution to community population health. I always like to say to startups, you need to be under-promising, over-delivering. Here's an article or a magazine from, was it 1924, talking about the revolution that was going to happen with the radio doctor, just as an illustrate the point. Some of the things that we get involved in, I'm not going to talk to this slide, but this is where we get involved in a lot of health data through the Digital Health Society, and here's an example of some work we did with a hospital trying to get them to understand the value of their data and how they curate that data and enhance its value. We then had a roundtable program, and this was called the Calls to Action on Health Data Ecosystems. It's been running 4 years. It's really about influencing the design of the European health data space, the idea that the public health data from the European Union will be available for secondary use as well as primary care use for anyone, citizens moving from country to country. We created the first roundtable results led to the 7 calls to action that you can see on this slide. I'm not going to read them to you other than to say I believe that these are truly global. There's nothing unique in many of these things that is applicable just to Europe, but we like to do things that are straightforward, practical, and deliverable. So the roundtable program led to a series of thought leadership papers. The QR code is on the screen. I'll leave it there for a couple of seconds. So if somebody wants to find these reports, you can do so. So I'm just watching some of the phones go up, so I'll give you a couple more seconds. Each roundtable had about 40 experts, so academics, industry, regulators, technologists, pharma, and scientists generally. So a lot of hard work in there. This is another thing that we do. I think at Health last year, I talked for more than a few minutes about European legislation in digital health. This is a slide I'm not going to talk to because we don't have time today. But I think in future, at Health next year, I think we will have a proper session on health regulation in Europe and what that means for digital businesses trying to do business in Europe. Now I'm going to just race through a couple of slides looking at all of the events that we do. So the first one here is Health, who are organizing their first move into the European market with Health Europe in Amsterdam in June, and we will have a partner program at that. This is the United Nations and the UN General Assembly in New York. So last September, we did our first 2-day science summit on health, which was a bit intimidating for those of us who've not spoken at the UN before or been involved in the event. But we are doing it again this year. So if you are interested in that as an event or getting involved in sponsorship, by all means, we'd be delighted to talk to you. This is our event in Africa rather, not India, Africa. And this is one of our partners, again, India, the Global Digital Health Summit, where we do much of the same thing that we're trying to do at some of the other venues. But this is just to illustrate, if you like, the global reach that we are having. MWC is Mobile World Congress, and this is Africa, and we were just involved in its launch. And unlike the European event, health was 40% of this conference, so we will be bringing more of our work to that. And then, obviously, back to health in Las Vegas later this year. And last year rather, we had something called the Global Health Village, which was the destination, the single destination for international businesses looking to come to health to meet US buyers, sellers, and partners, and vice versa. And we will be doing this, but this time the Global Village will be substantially bigger than it was last year. And again, if you want to join us in the village, please reach out, talk to us, because we will start to be organizing that event shortly. And then the 6th Digital Health Society Summit, unlike all of the others, this is a virtual event. And as you can see, we had almost 1,300 registrations from 95 countries last November. So it's taken off, and it's one of our ways, again, of communicating digital health and healthcare innovation on a global scale. So a sort of final slide. What we're really are looking for is people who have an interest in women's health. In particular, strangely, I have an interest in menopause. So people who've got menopause solutions want to get involved, please come and talk to us. Data and digital, and you're going to hear in the next session a little bit about our AI club from the person who led that, and the European health data space. Green health is a big topic for us. That's one of the things we spoke at the UN. The UN Science Summit I've just detailed. Africa we see as a really important market because it will adopt digital health far quicker than the developed world. Less regulation, less infrastructure, so there's a need to go to digital solutions faster and almost digital first. The very last thing, citizens' health strategies, is not the ECHAlliance. It's actually our 2 ambassadors who you're going to hear from later on, John and Nicole. And if you want to know more about what they're going to be doing in the US, please do speak to them. So with that, I'm just going to ask the panel up on AI if they would come and take the chairs, please. And we'll start with the first panel session. Thank you.
Yeah, so my name's Dave Bell. I have, for about the last 30 years, been developing technologies, some related to analyzing images, analyzing sounds, building mobile applications. There have been kind of big 3 focuses. For the last 10 years, I've been focusing, lucky enough to be able to focus on running a healthcare provider. So for the last 10 years, I've been running a company that provides in-home care for patients who are recovering from surgeries. So during the transition from focusing on building technologies to running a healthcare company, I had some culture shock, and a lot of great solutions I found very difficult to implement within the context of healthcare. So that's been a subject that's really interested me. And so my focus has been on trying to figure out how to get these many great solutions, and I think probably everybody in this room has been blown away by the things we've seen over the course of the last 18 months, but it's obviously been going on a lot longer than that. But I'm trying to figure out, how do I take those solutions and then make them applicable in the real world in the context of the healthcare ecosystem? The healthcare ecosystem is very slow to adapt. Just very briefly, 10 years ago when I started working in healthcare, everybody was talking about the digital health transformation, and we're going to take all the paper out of healthcare, right? And they were talking about it for 10 years before that, I assume. But if you flash forward to today, I think my company has less pieces of paper floating around, but I don't think my staff spends less time dealing with digital paperwork than they did 10 years ago. Maybe more, in fact. And so I think that's a cautionary tale of, how hard it is to take a good idea and make it work in the reality of the healthcare ecosystem. So we're trying to do better with that. So I've started a company called IO Health, and that's the problem we're working on.
Perfect. So I am the other Dave on stage here. When you go, you can get a new name. But so Dave Whalen, I run an organization called Bioscience LA. But as I was sharing with the team earlier, I am not an AI professional. I don't know if any of us are AI professionals, but as I was saying, I did actually, once upon a time back in the 1900s, studied AI in college and then proceeded to go into the business world and eventually the healthcare business world. And while I didn't actually do anything directly with that coming out of college, what's happened over the years is, one, the AI market has caught up with the technology, as we were talking a little while ago, but what I've been working on over many years is really this integration of business and healthcare, and in particular, how do we leverage data to help people make better decisions? And those people could be physicians, they could be payers, they could be the public sector, they could be patients, or they could be consumers who don't want to be patients. And what that means is starting to pull data from disparate sets. I've worked in the wearable space and the genomic space, and I have not worked in the EHR space on purpose because I just don't want to go there. But it's really about connecting these disparate data sets. And my role now, again, I run Bioscience LA, which is a nonprofit organization here in Los Angeles, part of the ECHAlliance, and we're growing the life sciences and healthcare innovation ecosystem in Los Angeles, which is a huge area with a diverse population, diverse industries, and so everything that we're working on here is connecting different kinds of organizations, different kinds of people, bringing together different sorts of data, hopefully to help people make decisions more effectively. So very excited to be part of this and see how we can solve some things on stage here today.
Thanks.
Dave.
Dave three?
Yeah, no, Dave 3. Davina. No. No, I'm Rachel Dunscombe. I'm a recovering CIO, and that's probably why I'm here. So I was formerly CIO of the most digitally mature organization in the NHS. 7 years ago, we were working on AI. We had data scientists. We were running data science programs with universities for our clinicians. And I got involved with the UK government as the lead policy maker for AI. So I worked on the AI roadmap and the AI strategy. So that was multi-sector. So I've got both policy experience, but also the scars from trying to implement AI in healthcare systems. So today I'm CEO of OpenAir, which is working in 114 countries to make data ready for the cognitive age, so ready for AI, because our data is not there, as we can probably see from a lot of things that are happening. But as Baden said earlier, I led the AI Club last year for the Digital Health Society, looking at what we need to do in healthcare to actually make AI serve humans. And my real interest is the stuff that probably people don't find interesting: governance, policy, how we actually get the human factors working. And it's all the things that surround these technologies, because my experience taught me that really it's about humans before technology. And so I am really, interested in how we integrate this completely with our healthcare systems and how we ensure that it's fit for purpose and safe. I think a lot of people are speeding into sort of innovations and then finding unintended consequences. So one other thing, I'm also a visiting professor at Imperial College London. And I'm very lucky to be able to publish on some of this and work with others academically on it. But we need a lot more evidence. We need a lot more blueprinting of what does and doesn't work. And equally, I was with the sort of WHO and others at MedInfo last July in Sydney, co-facilitating a session on this. And the big finding was we need to do some things globally. We need things like standards. So from my perspective, I really want to look at all of the systemic pieces around AI, not just those really funky innovations that are very interesting, but only part of the picture.
So great. So some mythbusters, first of all, okay? That sort of anxiety I have when I saw the number of AI slots on was hype. and the danger that technology starts to overpromise. And we need a balanced position. So I hope in the discussions that we have, we reach something around that. Also, though, the other side of that coin is for people to think that this is all about the future, when actually health has been using machine learning. Part of the problem is people don't know the difference between machine learning and AI, and it's like a buzzword that you're going to find on sales stands where there's a salesman talking about it. But don't understand that we've been using AI for quite a while. If we talk about radiology, and I'm sure that I know that Rachel's got 10 use cases for AI in healthcare. So maybe when we come to some questions, if you want to understand what that is, if it doesn't come out in the conversations, we can do that. But my first question, really, which is a quote. Okay, so it was said that those who can imagine anything can create the impossible. This is a quote from Alan Turing, who's often regarded as the father of machine learning and artificial intelligence. So the question really is, what do we see as some of the really exciting possibilities for AI in healthcare? Not necessarily today, but in our lifetimes, let's say, for sure. So who would like to start me off?
Can I start on that one? Yeah. So I think the risk we have with AI is a bit like the risk we had with EMRs, that we just digitized paper in the case of EMRs. And what we really need to do is reimagine healthcare with the capabilities that we've got. And that is really quite exciting. But the issue is, I think, that we just take spot use cases and say, we'll slot that in there. And we don't consider human processes, the future of work, the future of jobs, what we will need. And so for me, it's about systems thinking. And I think Turing was right there. I think we need to think systemically about what healthcare can look like with the capabilities. And actually, one of my biggest reflections is that the likes of boards that run hospital groups or healthcare groups do not understand the capability and how it unfolds. They cannot imagine what they need to design. And so for me, there is a massive education piece to do with boards to make them confident and competent and move away from fear of this to being curious and wanting to actually leverage it. So that's my observation.
I can just add to that, and I love where you started, Rachel, because processes are it's so important to be able to automate processes to make them work more predictably and faster. But of course, if we're just trying to automate something we're already doing, we're missing the boat, right? Which is really to re-engineer, as you said. But what I think is really important, and I'm just looking at the data and digital, and just thinking about the data side. One of the reasons why AI has been used for so long in healthcare, but I think the opportunity is so huge, is that we've got such complex sets of data which largely are disconnected. And so I mentioned sort of technologies like genomics and wearables and EHRs, and all of those do certain things sort of well, but they're not connected. And then when you start to integrate patient data and consumer data and environmental data and things like that, talking about the UN, Glenn, and sort of like the UN Sustainable Development Goals, of which almost all of which overlap with healthcare in some way, either from a problem or solution standpoint. It's bigger and bigger sets of data, and so what we really need to be doing is not just developing these point solutions for a specific condition or a specific technology, but really looking further ahead at how can we find ways to connect these data sets and do that sort of initial processing of data or initial analysis to even get the right data in the right place, so we can then have the right people using them. And so I see even just leveraging AI on, call it the meta system, right? How do we use machine learning to figure out how we could combine sets of data is going to drive huge industries that'll underpin everything we're doing.
I guess the thing I would add is that, when I think about providing care, as a provider, I think about three areas. So there's care that can be delivered with text or voice. There's care that you have to deliver in person. And then there's care that can be delivered with, drugs, devices, diagnostics, et cetera. And so if I think in those three categories, diagnostics are already using a tremendous amount of AI, so radiology being a good example. it seems like we're on the cusp, to your point of, what's coming next, that text and voice seems like it's well on its way to switching over. I mean, that's, for a lot of clinicians, it's not the the best use of their time. For the system overall, it's very expensive, and for patients, it's a poor solution as it currently exists today in many cases. So I think, that's an area where I just see potential for really rapid positive change. Just text and voice, instead of being $60 an hour with a nurse, it's less than $1 an hour or whatever it turns out to be with AI. The part that is a human giving care to another human, which is, I think, what a lot of us think of when we think of healthcare, I think that's the part that's going to take a long time, and it's going to be really hard to change. I mean, then you're talking about augmentation and minor improvements, important improvements, but I think that will be the hardest and most important.
So I think one of the things I really like what you said then, Rachel, was that when I was trained as a lawyer, my mentor said to me, you never sit in a room and don't understand something that's being said because you're too embarrassed. And so I think that point about boards and not understanding AI is something that we need to get out there so that everybody who's involved in healthcare is not embarrassed by saying, look, I don't understand this technology. I don't understand this particular point. Let's have an open discussion about what it means. So I think that there's no shame in not being cognizant of all of the rapid developments. If you start thinking about generative AI and what that's been doing, I mean, as we were doing the AI club, we were halfway through it, and then suddenly generative AI took off, and we were like, gosh, okay, reevaluate. So I think that's going to be really important for us. Can I take us to a second quote then, which is Stephen Hawking said, our future is a race between the growing power of technology and the wisdom with which we use it. So what do we think of that? So that's taking us, I think, down some of the stuff that we started to talk about with standards, ethics, governance. Rachel, do you want to start us off?
Yeah, there's a wonderful book called Designing Freedom from the 70s, I think it was 70s or late 60s, which predicted AI coming and how we used it to free humans and make them, live a better life, yeah? And I think we need to be very careful about what we do here, because we need to shape this to enhance human life and not use it to create less freedoms. There's an awful lot of power in AI, but we can use it badly or we can use it well. And so really, for me, it is about the wisdom of people and taking the time to make sure that we have the right systems in place to get this right. And that is really important. That includes everything from policy through governance through to, co-designing and co-creating with society. And so those constructs need to be in place. Humans, it's a bit like a kid getting, something new and running away with it, like a computer game and playing it 24/7 or something, isn't it? It's humans get carried away. I think we need to keep ourselves in check.
Yeah, just to add to that, if you think about AI as a new technology, and whether we're talking about the public sector kind of legislation or management around that, we've still in healthcare and still in government, we've not yet caught up with digital technologies. Period. We've not yet caught up with privacy. So now we're trying to solve yet another layer on top of that, not having actually figured out how to deal with who owns digital whatever, not knowing who manages privacy, and so it gets more and more complicated. So I don't know if we do need some wisdom, Glennon, which we don't yet have, but it really comes down to, again, continuing to ask, what's different, what are we trying to solve for, and helping everyone from the public to the elected officials to the companies that are actually doing the work, the academic institutions that are driving the research, help them figure out how can we have more of an open mind, but then also figure out what are the right guardrails, so to speak, so that we don't end up going down the negative path that Rachel mentioned, but we actually achieve something that could be great.
I think I may have somewhat of a contrarian view here a little bit.
That's just exciting. Now we can start
like
fighting
it.
on
Right.
stage.
No, but I think I have done some work on the risks of AI, and I am probably a little bit of an outlier in that I think that a lot of those risks are very real and things we need to worry about. However, I think healthcare has so many built-in safety stops. Healthcare, is 30 years behind the adoption of technologies. I don't think if we blow ourselves up or kill ourselves or do something horrible with AI, I don't think healthcare is where it's going to happen first, to be honest. So I guess I would say I'm much more worried about moving the needle in the other direction. I'm more worried about the slow adoption of AI. I'm worried about losing out on the benefits of AI. I wouldn't say that overall in other areas, nuclear war, for example. I think AI can do some damage there. But I think in healthcare, the focus should be 100% on how do we adopt technologies and use them to help people as quickly as we can.
And that's a great point, because I think that we all lose track of the fact that healthcare is about risk management. Mm-hmm. Doctors are not omnipotent. They don't know everything. They tend to treat disease by going through a process of it's not this. So that you imagine the first time a doctor saw an HIV patient, it was a process of elimination. It's not this, it's not this, before they realized we've never seen this before. So fundamentally, as a lawyer, I relate to this because for clients, it's about risk management. So I think it is about balance again. I come back to that we need a balanced perspective on that risk. And as you say, we strike the right balance between innovation and not slowing up, but also not blindly adopting without any understanding of what we're doing. So I think that in the audience, you are all involved in healthcare. So one of the things that I think is we need all of you to take the balanced view, to actually take that message and talk that message. Because if we don't, then actually somebody who has more of an extreme view, whichever end of the spectrum they're on, that's the message that's delivered in the vacuum. So we need to make sure that we are talking about the benefits and explaining why all of the checks that are in the system already and coming down the line. But I want to just talk about international for a second. So in the ECHAlliance, we talk about the fact that one of the reasons we exist is that tech is global, medtech's global, pharma's global, healthcare is at best national and more likely regional. So it keeps reinventing the wheel. It keeps explains the variation in outcomes and the inefficiency in cost. One of the things that we need with AI, I think, is not to have individual country-by-country solutions, because the data is many cases is going to come from outside of one country anyway, and we need to see collaboration. So I'm wondering, Rachel, because I'm thinking of the AI Club, we came up with a number of recommendations. I wonder if you can just talk to us a little bit about that.
Yeah, so I think this is global, as you said, and patients travel. Even if we look at Europe, there'll be the European Health Data Space with health passports, yeah? The point here is that we, as you said earlier, we've got proliferation of different standards as it is for data, let alone AI. And if you look at the European Union versus the US versus others, we're putting different standards in for the certification of AI. I think, the WHO has said that we need to converge on some of these things, because not only is it, it's stopping people doing things, it's slowing, it's a friction, but equally, it's not allowing companies to design something that is globally fit for purpose, because they're having to adapt to each market. And as we've got it at the moment, it's suboptimal. So the question is not really, do we need to do this? I think people know that we do. The question is, who can lead it? Is it the WHO? Is it the UN? Who is it that can lead some of these standards for healthcare? Because we need it both for the data on which, we train these things, but also for how we do both certification and life cycle management, which is key, so managing it for its life. We need to create some standards. And, we've got standards for data interoperability, things like FHIR and so on that are taking off globally. We need to be looking at that for AI, and that's still emergent.
So coming at it from a slightly different angle, because as I think about some of the solutions, a lot of what we work on in Los Angeles is not just the delivery of healthcare, but also the research side of things, which is leveraging AI for the development of new diagnostics, but also the development of new therapeutics. And I think the research community, whether it's the academic research community or smaller startups that are trying to build new solutions, there's a great opportunity there for that kind of data sharing and collaboration. The academic research community is constantly going out to find ways to collaborate, find ways to share data. And again, this is outside of the risk area of delivery of healthcare. It's earlier than that, so it provides an opportunity to kind of open up some of those sets of data, build collaborations, and it's also another place where AI and analytics, machine learning can be so powerful because it's helping to identify patterns, it's helping to find connections that might be an individual research finding here, and an individual diagnosis there, and somebody's hypothesis over here, and these systems will hopefully be able to help combine that in a way where somebody else can develop a new company, develop a new therapy, come up with something new. And so I feel like we can do that outside of that regulatory world a bit.
I guess this is a challenge that every service business faces, right? Especially a local service business. But I think that the solution is always going to come down to sharing data, sharing best practices. And, so I think you're not going to get providers moving all over the place. In a few cases, you can get patients moving all over the place, but if you have a heart attack, you're going to the local hospital. But best practices and data and models and AI can move across borders very easily, and that seems like the area to focus on.
Yeah, definitely, and that's obviously where the tech companies, whether that's AWS, Microsoft, a lot of the analytics businesses, that's where there's a lot of hype about, concern about what can they be trusted, and that's one of the things I think we need to tackle. And I think to your point earlier on about not wanting to see innovation slowed in AI, this is where we need a balance again between, I think, some of the views being expressed. I mean, I do find it funny that about 20 years ago when I got involved in healthcare, I came across this word interoperability, and 20 years later, people are still talking about promising to sort it. And that's the worry that I have, and that's the lesson I think we have to learn with AI, that we don't repeat interoperability. So on my last dying breath, I'm still talking about AI implementation and adoption. So that's a challenge for all of us out there to recognize that actually self-interest sometimes plays a big part in why interoperability is still the challenge to the healthcare system. Right, so we've got a few minutes. So we have a mic. So is there anybody who wants, this is your chance to get some free advice and to ask that difficult question, okay? So don't be shy. So we have a lady, oh, no, we don't have the mic. Okay, hang on, I'm gonna come to you. So if you can say your name, where you're from, and then your question.
Hi, Marwa Yunus, I'm from Canada. I'm just wondering, what are your thoughts on the role of health technology assessors globally? So Nice in France, the National Institute for Health and Care Excellence, but also CADITH in Canada, and I'm sure there's American equivalents, but what do you feel the role they play in regulating technologies that may have AI employed?
So certainly within Europe at the moment, we're seeing CE marking of apps, and within the UK we've got the MHRA as well. So this is quite funny. I was sat with the chief exec of the NHS about 3-4 years ago with 14 regulators in the room trying to work out who was going to do what. And we're still working out who is going to do what, but we're down to 2 or 3 regulators in the UK and probably a small number in Europe. The role appears to be at this point for initial certification, so CE marking. And it's interesting for me because you need to monitor these things as they progress, as they're retrained, as you use it on new data. And I think that the role of the regulators will become one of continuous oversight, which will mean that they're managing any exceptions that are actually raised, but that needs sort of systems that can monitor things. And we still don't have an industry of sort of vendors that can provide those oversight systems. So for me, it's still very emergent and they're still very much learning, but I think we are starting to get some sense about how we can certify and then have oversight of these algorithms, yeah.
I would say that in the US, what we're seeing is that the existing regulators are applying the existing standards. And so, if it's devices, they're applying existing device standards. If it's an EMR, they're applying existing EMR. If it's an existing provider, they're they're applying existing provider standards. So the standard is essentially not, it's agnostic to AI or whatever's under the hood, but it's focusing on, does the end result meet the requirements of the existing regulation. I don't know if that's a good approach, but at least it is opening the playing field for people to make innovations in AI without being specifically held back. But probably more is going to be needed, but that's currently what's happening on the ground.
So I think the lawyer in me can't help but make a remark here. So before Christmas, there was a really interesting consultation by the European Medicines Agency, who were very enlightened, and they had a room full of all sorts of organizations, from industry to specific types of regulators across Europe. And what I'd encourage you all to do is don't take the approach to just say it's going to happen and it happens to you. Okay? It's incumbent on all of us, when there are these consultations, to actually engage, to inform your concerns, your evidence, so that actually we get, I hope, fit for purpose standards emerging and approaches emerging. I think that it's really clear that AI, perhaps more than any other technology, is challenging regulators and governments across the world in a way that hasn't happened before, which is beginning to trigger, I think, a more collaborative approach. We will, at the UN, push this message because we just need it to be apolitical. It's not party politics in any particular country. This is too important an issue, so we'll do that. So with that, we're running to a conclusion. So fantastic. Thank you all very much for the panel. And if you would show your appreciation in the usual way, thank you.
Welcome, everybody. As you can see from the slide behind me, this panel is going to be on a different topic, although we will have some themes that are going to be consistent, I think, in the conversation, as you will hear. We're going to be talking about healthy aging, and the particular focus of this session is driving wellness in the 50-plus population, although I think we'll be hearing that it isn't necessarily even the 50-plus population. Healthy aging starts a lot earlier than that. I'd like to start with some introductions, not to say much about myself. My name is John Warner. I've been working in and around the aging and aging tech space for about 15 years now here in the US, despite this accent. So most of my time has been working on the US side, issues and innovations. But I'd like to my fellow panelists to introduce themselves. Scott, at the far end, perhaps we can start with you.
Sure, thank you. Good to be with you all today. I'm Scott Collins with Linkage. We actually were started by a group of not-for-profit senior living providers in the mid-90s to focus on managed care. They pivoted the business a few years later to group purchasing. And so we're kind of a multifaceted organization. Fast forward to today, we have more than 1,000 locations of independent living, assisted, skilled nursing, CCR, continuing care retirement communities, large footprints in home health, affordable housing, and hospice. So really, any way there is to provide supportive services to older adults, our owners, like I said, the not-for-profit groups, as well as members, do that. Along the way, we realized we couldn't cost-cut providers into long-term sustainability, so we created a venture arm to invest in companies with products, services, and technologies really focused in the healthcare and aging space. So in 2014, created one of the early funds with a partner out of Chicago. And to date, we have 3 funds, a little over $112 million in capital raised, 38 investments. Really having a nice impact. And one of the things that jumped out at us, though, when we'd ask people, how'd you come up with this idea? The answer was usually, I would have done this if my mom had that or my grandmother. So we actually built a market research consultancy to help people better understand older adults as consumers. So instead of putting a plus sign on age 65, we go to over age 100, breaking it down in 5-year increments, not just for the chronological purposes, but so that we can understand the various life stages. And then most recently, we created a company called ECHAlliance to break down the silos in healthcare and create companies ourselves in partnership with providers from across the ecosystem, payers, policymakers, and most importantly, older adults at the center of the transaction.
Danny.
Thanks, John. Wonderful to be here. Danny Kaplan. I've been working at this intersection of senior care meets technology meets healthy aging for about 11 years. I also grew up with an older father who was 58 when I was born. I'm 35, so I'm the young one of the bunch. I've known these guys for many, many years. Let's see. Got my start kind of career side, senior care, 2013. Worked at a company that made web-based software for home care agencies. Grew with them from I was the 13th hire to 120 people. Wore a variety of hats. Customer support, customer success, account management, business operations. Traveled to over 30 states, meeting our customers, learning about them, their businesses, what mattered to them. That company was acquired by a private equity firm in 2016. Found my way down here to Los Angeles. Went to USC, got an MBA and an MS in gerontology. Spent about a year and a half while I was in grad school interning at Generator Ventures, which is one of the, I guess the second established venture fund right around the same time. For lack of a better term, age tech venture capital fund. Interned for a year and a half, joined full-time June 2019. Helped them invest the majority of the fund, and departed this past October to focus full-time on a firm that I co-founded called Equitage Ventures. Equitage stands for Health, Equity, and Age. We haven't publicly announced, I guess I just did, or launched the firm yet, but hope to do so in the next 2 to 3 months. So.
Excellent. Okay, so we know who we have on the panel. I'd like to go just to a couple of slides to set up the conversation with my two colleagues. So if I can have the next slide. And it's as much as anything, it's just for context in the conversation we're going to have, because we've given this a title of healthy aging. And I think as Danny and Scott said to some extent, we struggle a little bit to describe our sector. Is it age tech? Is it aging innovation? Is it just aging generally? So in this case, we want to really unpack that whole idea of healthy aging. And I think there are a couple of things I'd like to say. On this slide, very simply, we've seen this is government. This came out of the White House over 20 years ago. But essentially it says we should be getting upstream. If we focus downstream at the bottom of that chart on the individual impact, we are going to be spending all of our time dealing with sick care. Because people are going to run into problems almost inevitably as they age. And we've got to get upstream from that. In fact, this was a physician, 1974, John McKinley came up with this diagram originally, so it goes back all of that time, and said if you really want to go and make the change, you want to go and get upstream to the top of the river and find out where the problems are coming from in the first place. Why are we deteriorating into disease and anything that shortens our health span? And then if I just go to the next slide, just again for context purposes, there's a lot on this slide I realize. But essentially, I've said right at the top, there's two forces for change that I think are always worth thinking about. And this came from the work, for those of you who remember, from Kurt Lewin. Kurt Lewin was a psychologist, actually spent quite a bit of time in the States in his later career in the 30s and the 40s, and ended up saying you can't just think about change in terms of its positive forces. You've also got to think about drag and friction on the other side. And I think that's a context for us in healthy aging, because if you look at the top right, this conference here at ViVE is very much about positive forces. Where can technology take us in a good way? And everything you see on that slide, whether it's getting into genetics, genomics we've heard about earlier today, or digital health, or whatever it may be. But underpinning that are a whole bunch of human factors. Even on the right-hand side, when they're still positive drivers, do individuals have the capacity to, to change? But what can interest me the most, and I think in this conversation we'll go to a fair bit, is what's on the left-hand side. Where is the drag, where is the friction, where is the resistance that we also have to account for, so we can reduce, lessen, and improve those areas. And there's a ton of them on that left-hand side. At the top, they're sort of more health-related, so to what extent are those things in people's lives today, and in the bottom are much wider contextual issues that we should be taking account of. So the conversation that we're going to be having is going to be much more about those wider contextual factors and not just about technology for its own sake. So with that, I'm not going to particularly talk more about that slide, although we're more than happy to share the slides for anything you see in the previous session, this one and the one subsequently. For anyone in the room who wants them, please contact us. So let me throw, and Scott, I'm going to go back to you. So let's talk about the goal of healthy aging as a concept, and what you perceive gets in the way of improving it or accelerating in a positive and efficient way going forward in the future.
Yeah, in our part of healthcare, there's the term aging in place, which I absolutely loathe. It implies that, you're just waiting for something bad to happen, as opposed to choosing to thrive and live your best life wherever you choose to call home. And to me, it's interesting. So much has to change in terms of the perception around aging, because so much of what I see in terms of either things that people come to us with investments are really focused on more the chronic aspect of older adults, as opposed to how can we help them really live their best life, and along the way there tends to be this overlooking of the social determinants of health, and how this idea of access and affordability really is a huge barrier to a lot of these wonderful things that are being invented. But we have to remember that at least the part of the world that we cater to in aging is a very narrow slice of it. The vast majority of older adults in this country really lack the means and the resources to take advantage of all these wonderful new initiatives. So we have to really think about affordability and access.
Danny, same question for you.
Yeah, I would say healthy aging really starts before age 50, before age 65. Everything that kind of dictates how well and how healthfully you age. It really kind of comes down to the decisions, the social, the lifestyle, the educational decisions that you make when you're a younger adult. And I think this all kind of boils up to where we find ourselves today. What you kind of talked to is, there's a lot of chronic conditions out there, and I think that means that our healthcare system is one that's very reactive. It's one that's not proactive, and I think that as investors, Scott and I find ourselves looking at a lot of companies that don't actually have all that much to do with healthy aging. They have to do with how do you manage and control chronic conditions. That's definitely great that we want to manage and control those chronic conditions, but there's not a lot out there. When it comes to kind of how do we help people actually thrive where they choose to age. And I think that Scott's point on affordability really, it really hits home. Just to share two really quick numbers that I think are really important. The mean income of someone age 65 plus, about $75,000. Mean income. The median income of someone age 65 plus, it's about $47,000. And the average cost of assisted living, something that many older adults are going to need, in their later years, is about $54,000. That's $54,000 of after-tax money. The $75,000 and $47,000, that's income. That's pre-tax AGI. So, I think that this issue of affordability, who can actually afford to age gracefully, and who can actually afford to choose where they age, that is something that I don't think we talk enough about.
I could not agree more.
So let me add to the statistics a little bit, since you both raised chronic conditions. So one of the big contextual factors is we spend something like 85% of our $4.5 trillion on chronic conditions. It's a crazy high number. Another 12% is spent on episodic sickness. So you might have broken a leg or whatever it is, you're going to recover from, but nonetheless a huge amount of spend. That leaves 3% left for preventive and wellness side intervention. So this is, I think, one of the things contextually we have to think about as a drag factor in terms of where we're going. The other point before I ask the next question to make is, I think you both alluded to the fact that healthy aging starts at a very young age. Yes. In fact, I tried to represent this even on the chart and forgot to mention it. If you're 7, as you are those people at the top of that chart, getting to 10 takes some navigation. The parents want to make sure that child is developing. Or if you're in your, you're 35, as you might be in the middle, getting to 50 takes a whole bunch of activities that actually are in your interest in terms of thriving in the long term. And I think that's why we're having this conversation. How does that happen really along the whole continuum? And it starts to change the way we even think about education and literacy and access, as Scott said. So I think these are all crucial issues in terms of this subject.
John, one resource on that, the International Council on Active Aging has done some absolutely wonderful work over the last 15 to 20 years on really helping people map out what's that journey look like in terms of what's successful aging. And if you want to be able to play golf 4 times a week when you're 85, you don't start working towards that when you're 75. What are those things you need to do from a functional fitness perspective?
Yeah, and imagine it in the first place.
Yeah.
So let's take that further then. So let's talk a little bit, and Scott, again with you first. Where are you spending most of your time as it relates to healthy aging? And where do you see the greatest gaps from your perspective, having been involved in the investment space and in the post-acute space for as long as you have? Gaps that we need to address in terms of changing things for the better.
Yeah, I'll answer it 2 ways. In our private equity funds, we see an awful lot around technology-enabled services for older adults in some sort of post-acute setting in a value-based contracting arrangement. That we see a lot of that. What we're interested in Linkage Launch in terms of the companies we want to build, we're really focused on the healthcare workforce. Because we can create all kinds of terrific solutions, but if we don't do something to stem the tide on turnover and the vacancy in healthcare, there aren't going to be people to deliver these wonderful solutions. So the first couple businesses, we're really focused on how do we regrow and retrain and revitalize our healthcare workforce.
And how does technology play into that,
Yeah.
Scott?
So we've looked at a number of different things. One of our first companies that came out of the launch is called Healthonomy, using hyperautomation to either assist, augment, or fully automate certain parts of the operations, particularly on the administrative side. But it allows you to do more with less and get the people you do have focused and engaged where automation isn't necessarily best suited. And then the other business is a completely reimagined health and wellness benefit platform to help better attract, delight, and retain employees, to create that stickiness in healthcare so that people aren't forced out of this industry and doing something else.
Danny, same question. So again, where are you spending your time? Where are you seeing opportunity gaps in this whole pathway we're discussing?
Yeah, absolutely. Just the note on workforce. It's a crisis. It's not a problem. It's not an opportunity. It's a crisis. I fundamentally think that technology will play a huge role in changing it and making it better. But I also think, this may be an unpopular opinion, but I think that immigration reform is probably the number one thing that we can do to help address some of the gaps across the healthcare workforce. I don't care if you're talking about a home health aide, a home care aide, a CNA, an LVN, an RN, doctor, surgeon, just across the board. But at Equitage, we work with our LPs, as Scott does too, to identify areas that they're very interested in terms of investment. We have a very purpose-built LP base. Individuals, entities, corporates from kind of across healthcare, senior care, long-term care. And I think kind of two kind of broad-based buckets that we look at. One, senior care is a really interesting world. You've got home care. That can mean personal care and companionship for the most part. That's private pay. That can also mean home health. For the most part, that's, Medicare or Medicare Advantage paying. There's senior living. That's private pay. Medicaid pays for some of it in certain buildings in certain states. It makes sense to be able to take Medicaid, Washington and Oregon being two of them. There's post-acute care, right? That's predominantly Medicaid pay and Medicare and a little bit of private pay. There's acute care, right? And insurance, not a lot of private pay. There's end-of-life care, right? So all of this to kind of say that there actually aren't a lot of companies that you can invest in that kind of take like a standard approach to working with all of these customers. There's not a lot of companies you can invest in that that works with a customer whose predominant source of revenue is private pay, and also whose predominant source of revenue, a different one, whose predominant source of revenue comes from Medicare. It's difficult to do that. So one of the areas that we see a lot of opportunity for innovation in is bringing senior living closer together with the healthcare system. Across independent, assisted, and memory care, those businesses have predominantly been real estate businesses, and after that, they've been hospitality. We all know, everyone under this roof knows that what goes on in senior living is actually healthcare. Yes, there's hospitality too. Yes, it goes on in a building, so there's real estate too. And that's also important, but it's a healthcare business. And I think that access to senior living, quality senior living, is out of reach for most Americans. And I also think that most Americans don't know that Medicaid or that Medicare doesn't pay for long-term care. So they also confuse senior living with skilled nursing. So I think that kind of how do we make senior living more accessible and bring it closer to the healthcare system is one area that we're very excited about. And kind of a second spot is just in post-acute care, broadly defined. Going a little deeper, I think anything that we can do to make nursing homes better is going to be really important. I think if you look at what the payers are trying to do, we can have a whole day of talking about the changing rules and regulations that they are faced with. One of the ways that they are reacting is moving patients from SNF back to home, and sometimes it's appropriate, and sometimes it's not called for yet. But what that means is these nursing homes that have mainly been kind of chronically underfunded and under-resourced and understaffed, are left with a population of patients that are higher acuity than ever before. And I think that there's just a huge opportunity to make nursing homes better places to live and better places to die, too.
One other thing I'd add, because I love how you laid that out. One of our owners is the largest not-for-profit provider of affordable housing in the U.S. HUD 202 programs, tax credit, finance properties, supportive housing for people over the age of 50 who qualify for economics, or people with permanent disabilities. I think within that construct is an unbelievably rich research environment for people wanting to build solutions for older adults, because that's very much what the vast majority of the aging population looks like in our country. And if you can build solutions with those consumers and understanding those unmet needs and how to actually build the economics, the pricing models and go-to-market strategies around that, I think you solve for affordability. You also solve for access, because there's lots of things going on in dense urban centers, but so much of aging takes place out in rural areas, and the challenge there is most of the younger population has left to go pursue jobs elsewhere, so they're not staying behind to care for an aging population. So,
very good, very good. Let's go a little deeper in terms of a couple of subjects that you both mentioned. You obviously both invest in this space and have done for a number of years. So I'd like you to talk a little bit more about what should the focus of investors be? We've had a really interesting 2023. Many investors have caught cold around areas like digital health, for example, but particularly as it relates to the older adult space and with keeping this healthy aging aspect in mind. It's a two-part question, really. What should investors be thinking about? And then for the entrepreneurs in the room, what should entrepreneurs be thinking about in terms of sailing into the gaps in the marketplace that you've alluded to? What are some issues for you, Scott?
Well, you hit the nail on the head, John. Investment in digital health has dropped precipitously over the last few years. 2023 actually was the lowest invested year since 2019. I think it was roughly a third of the high point in 21. So what we're seeing is, for investors, you got to get back to the basics. Look at the financial fundamentals of the company. Look at the leadership team, and not just the people charged with building the product, but people charged with building the go-to-market strategy. Have they done their homework around understanding what those unmet needs are? Do they understand who all the parties to the transaction are? The buyer, the influencer, who's the economic buyer as opposed to the emotional buyer of the solution. So I think there's that piece of it. And then there's more and more focus on going back and looking at the financials. It used to be if you could get to that magical 10 million in ARR, it didn't matter how much money you were losing, you could have a pretty nice exit. Not so anymore. So, investors are being much more discriminating in terms of the deals they want to invest. Term sheets are definitely falling in their favor. And it's going to be that way, I think, for a little while to come. I don't know, Danny, if you have a different perspective.
No, I don't. I agree with you fully. I think some of the things that we're looking for as investors, just in no particular order. Well, I think first and foremost, I would say that, we are technology and technology-enabled services investors. I would say most of that probably leans more towards tech-enabled services. I think technology companies create a lot of value for their customers, but they really aren't in a position to capture a lot of the value. So I think we've seen a lot of companies say, back in 2020 and 21, we're building tech for this or that, and now they're coming back and they're like, yeah, we're still doing that, but we're doing some services too. And, maybe they're providing care, maybe they're doing, some kind of admin work. And I think that there's a lot of opportunity there. So I think we kind of lean more towards services businesses. I think any business that accumulates providers and patients is going to be attractive for an exit, whether that's to private equity or to one of the payers or to one of the large providers. I think when we look at a technology-enabled services company, I think having a really healthy payer mix is important to us. I want to see that you can work with commercial pay and Medicare and Medicaid and managed Medicaid and maybe Medicare Advantage too. I know that's a lot. You don't have to do it right out the door, but I do think that if you look at the most mature publicly traded provider organizations, ApolloMed, now Astrana Health being one of them, they have an incredible capacity to work with a variety of payers in a really, in creative and profitable ways. And I think that's cool. Last thing I'll say, when we look, again, really at technology-enabled services companies, a lot of it is care model diligence when you're looking at a company that's seed stage or even Series A. And, as someone who's been around this for not a long time, but a little while, I think it's really easy to read about a care model, look at something and say, man, this kind of feels like it would work. This kind of feels like outcomes would be better and costs would be lower, and this sounds cool. But a lot of times there isn't an evidence base yet, and I think that a lot of times, the first money in the door to help de-risk these companies at pre-seed or seed, those companies should, I don't want to say what they should be doing, but they should consider using that money to go gather a really compelling evidence base. Something that they can use to raise money from, and one that they can use to sell when they go to, sign deals with payers.
Thanks, Danny. I want to allow time for a couple of questions, but if I can just ask you both, Blethen earlier on talked about best practices. Perhaps you could both think about perhaps an example of, maybe an organization you've worked with or a startup that's actually in the healthy aging area and is doing interesting things. So, Scott, do you want to have a first go at that one?
It's not one that we actually invested in, but Discover Live is a really cool company. They actually are able to use, I'll just say it like GoPro, okay? But they have guided tours all over the world, and older adults can actually go on these tours virtually, and it's a two-way communication with the tour guide. So if that guide is walking down the street and they see something, that the older adult sees something in the window that looks cool, hey, hold, can you go back and look at that? And it just opens up the world tremendously. I wish I don't even know if they raised capital, but they're in our group purchasing portfolio. They are absolutely fabulous. I mean, in terms of allowing people to just experience things that maybe they either don't have the ability to economically or physically, it's really cool.
In fact, just to pick it up on that very complex chart that's still up there on the board, I think you see a lot of laughter, happiness, and love in products like that, which help it to go viral and grow. Danny, what about you?
It's not. It's healthy aging, but it has to do with nursing homes. So I'm just gonna put that out there. Third Eye Health, a company that that my previous fund that I was fortunate enough to work at, and Ziegler Linkage are our investors in. Third Eye Health provides virtual urgent care to nursing homes on nights and weekends when doctors don't want to work in nursing homes. A lot of times this is when residents have something happen, and today or in a nursing home where there isn't Third Eye Health, what you do is you just put that patient in an ambulance and they go right to the hospital. Third Eye, I don't want to share too much data, but I know the number of encounters that we're doing every single month is in the tens of thousands plus, and our treat in place rate is 90%. So I think that even at ViVE, I think you'd be hard pressed to find a company that's actually directly creating more value for the healthcare system than Third Eye Health.
Excellent. Thanks, Danny. I think we've got time for at least one question back at the room. If you'd like to just introduce yourself and ask your question.
Hi, everybody. My name's Emily Michelle. I'm with Flex Together. We do virtual pulmonary rehab. And obviously, we're really interested in telehealth. And you had mentioned on the panel that a lot of folks are doing more services at home. Sort of what are areas that really excite you about this ecosystem around that patient in the place that they choose to live in? And what do you think the role is of telehealth in that sort of ecosystem among, other types of services?
Big question, Emily, but we'll keep it short. Scott, do you want to go first?
No, go ahead.
Danny, you go first.
Emily, okay, well, I love Emily's company. You guys should go check it out. It's like one of my favorites. I think the role that telehealth has to play, I don't think it's the end all be all, but I do think that it is, when it's used as an intervention in coordination with other services, whether that's in person or other virtual ones too. I think it's hugely effective. I think of telehealth, assuming that older adults have access to the internet, which is another thing that we can talk about all day long. I do think that it really solves, for many, an access barrier. I don't care if that's affordability or if it's just getting to the doctor. I think that that's just a tremendous promise of telehealth, whether you're in a nursing home or senior living or at home. I'm very bullish.
Just briefly, Scott.
Yeah, totally agree with what he said. I think it's a great enabler to allow people to remain independent, and it can be a tremendous safety net as well.
Great. Just to finish off before I thank the panel, we're announcing today at ViVE that the ECHAlliance are starting what we're calling the Healthy Aging Thematic Ecosystem, as you can see on that slide, servicing and spreading international best practice. We would love people to participate in this ecosystem going forward. This is a new ecosystem for the ECHAlliance, in which we'll be covering not only the 8 items you see up on that slide, but many other topics that we've had too little time to talk about. I can't believe how fast these sessions go. We could dive so much more deeply. But please contact us if you want to get involved with that. These meet 4 times a year, typically. And we are going to be having a lot of fun looking for best practice around the world in this subject of healthy eating we've been talking about. But with that, I'd like to thank my fellow panelists. And if you could join me in thanking them, that would be great.
Thank you.
Thank you.
So, y'all doing great? Awesome, awesome. Well, we're going to talk about my favorite thing, which is women's health. ECH, well, first of all, there's kind of a theme that's been going around today, and that would be, thank you, about the evolution of data and how it needs to be better for our system, the evolution of how we care for the wellness of as we age, and we're going to talk about the evolution, the science behind femtech evolution. And I have a wonderful panel here of experts and CEOs of femtech companies. But first of all, before I start, because I want them to introduce themselves, I want to talk about this past year, and even before then, ECHAlliance has really focused, the Global Health Connector too, as you see that. We've really focused on women's health, but really bringing femtech leaders and organizations that support femtech. And really, we want to uncover all of the issues that are faced today. And as one of the 51% of the world's population, I think it's something that we really need to pay attention to. We've gone through many of these talks where we talk about research. They even use male rats for clinical trials, right? A lot of our gold standards are based on male composition and how they present. So this is not a bashing thing. This is all good. What we're trying to do is we have 3 leaders here that are really helping to further how we look at women's health and how we impact them. So I'm going to let you all introduce yourselves, and then actually I'm doing it in order. Okay, so at our house, we do everything fairly. So I have a little order that I'm going to ask everybody, so everybody gets to be first. So I'm going to start it. And Aubrey, you are first.
Thank you.
Would you like to introduce yourself?
Sure, certainly. And just a thank you to the ECHAlliance. A pleasure to be on here. My name is Aubrey Kelly. I am a founder and CEO of Rabble Health. I'm going to start off with a founder story. So for those of you that are also health tech entrepreneurs, I think each of us are super passionate. Why else would we be in this space when investment has gone down to a third of what it used to be a few years ago, right? I came from the pharma side of the world, so I would just add that there's really 4 entities that we can sell into as digital health entrepreneurs. The 4 Ps, right? We've got payers, we've got providers, we've got patients. We also have pharma. My founder story is that I'm a pediatric cancer mom. So the moment that my son was diagnosed with acute myeloid leukemia, I came in also wearing the pharma hat. I was like, pharma, you're spending billions of dollars to educate consumers. Not so much in Europe, because different privacy laws, but certainly here in the US. Where is it going? You want me to consent to share his data. You want me to learn about clinical trials. You want me to advocate for better biomarker testing. You want me to switch my oncologist if my oncologist is not prescribing in according to my goals of care and his goals of care. Where are you? Why is that money not being spent efficiently? I created Rabble Health. We have a consumer health tech platform, and I'm obviously biased towards pediatrics and blood cancers. So we have sold into pharma, and we run initiatives to address social determinants of health. Our first pilot has been published. We support the Black breast cancer community in Memphis to address social determinants of health. We work with kind of that synergy of strategic partnerships and tech backing. And that's Rabble Health.
Rachel?
Hi, Rachel Kim, CEO of Femtech Salon. So I'm a community pre-accelerator and events organizer. Femtech Salon, we've done it nationally, but what we do is just amplify diverse femtech founders and actually drive and create the ecosystem for them to thrive, particularly from their 0 to 1. So 80% of the femtechs that we work with, which is over 100 of them, are in the pre-seed stage, which is actually highly critical given sort of the climate. With regards to my story into this space, for me, it almost took me 4 doctors and not my dying. I worked 10 years in tech under Accenture, got burned out, and you'll see some stats, I'm sure, you know, from the WEF report, at least 50% of women spend their working life, so from 20 to 65, being in poor health. And for me, even though I went through that experience, in context, I'm not that unique, if we really think about it. So as I've gone through my journey as a founder and community builder and also investor, I really wanted to utilize my skill set of being able to ecosystem build, which is what I did for Accenture. I trailblazed a lot of like new strategies, and therefore really wanted to aim that for social good.
Emily?
Hello, I'm Emily Stein, CEO of Primal Therapies. I am a microbiologist by training and a granddaughter to a lovely woman who had a stroke one day because she had a tooth extracted. And in retrospective analysis of thousands of Medicare claims show that if you get a dental implant or a tooth pulled, you have a 50% increased risk of getting a heart attack or a stroke within 4 weeks after that procedure. So I basically biohacked my grandmother, and 13 years later, multiple clinical studies, we now have been following the microbes that inhabit us, which account for 90% of our metabolic capability, and we've developed and devised products that can modulate the metabolism of the microbiome. And so that, believe it or not, the oral microbiome is taking us into women's health quite quickly.
Awesome, thank you. I'm going to just flash up some of these statistics. Rachel, you kind of touched on some of them, but before we go into the next questions, I just want to say McKinsey had a great report that came out in December, I think it was, and it talked about women spend 25% of their time more in poor health. Other studies talk about women report 30% feel that they're told they're a hypochondriac because of the symptoms that they're having. Only 9% of medical institutions offer a women's health course. We're training our doctors and our nurses. And yes, it's part of the whole human body, but actually having how to deal with women's health is being taught in only 9% of our academic institutions. That's kind of crazy, right? So that's why I think this femtech evolution is so important, right? So I think you all have kind of shared your story. We were going to talk a little deeper. Feel free to talk deeper as we go, but I think I'm going to jump ahead to our question on what hidden potential are each of you looking to innovate in your scientific approach to women's health that could truly revolutionize the industry? And with that, I'm going to just go back this way with Emily.
Sure. So obviously, we're really focused on heavy-duty science and discovery. So we've taken a multi-omics approach to really understanding who's living in us, what they're doing, and there, believe it or not, is a very big gender bias, and it changes over as we age. And so anything from grant funding or lack of grant funding, we touched on this earlier, but animal models, how we think about setting up experiments, even how the FDA decides and predetermines experimental design for clinical studies has inherent bias in it historically. So I think one of the things we really need to do together as a large community is really focus on building in equality into how we think about research, funding research, and really building out reporting of research and results.
Great. I'm going to actually go to Aubrey next.
Ooh, all right.
Sorry, I skipped.
So I'm going to focus actually on the lower middle statistic that more than 80% of women make families' healthcare decisions. And I'll go back into our model of being able to sell into pharma. So how many of you in the audience have ever met an individual that kind of has the ostrich head in the sand approach when it comes to healthcare? Doesn't have to be you, just someone in your family maybe? Okay. That's not the person that pharma wants. Pharma wants those people that can self-advocate, right? And sometimes it's not the individual person who's diagnosed who's self-advocating, but it's actually the women and the families, because let's be honest, we're kind of the ones that are making the healthcare decisions. And so what that means is that technology that's really looking at helping to measurably show that people are self-advocating need to help not just the person who's diagnosed, but also their loved ones, right? So how powerful is that we can create a business model to actually help women in the nuclear kind of, circle around supporting a patient, help self-advocate, ask for clinical trials, learn about biomarker testing, learn about different ways. And so our business is really focused on that piece of being able to help not only women supporting other women, but women supporting men, and ensuring that we're able to reduce the barriers to help them do it.
Awesome. Great, thank you. I think I'm going to go right to you, Rachel.
Should we? Well, to set the stage, I think in femtech, we're in what I consider, from a consulting perspective, the unknown unknowns. I think there's a great green space, there's a great market opportunity. I don't agree necessarily with the McKinsey statistic that it's 28 billion this year. It's actually 1 trillion. We're already there, and that's just a starting point. So when we think about the science that I bring, I look at how people connect and actually care about femtech, and that's on a sociological level. So if you think about sort of a thriving ecosystem in general from nature, you need to have the social and climate and culture. So we drive that through community events, being able to amplify connections, but also sharing stories. And stories is really the difference of, you have the statistic, and we're in the world of statistics, but how do you get people to actually care on a human level? Having the knowledge and processes and tools. Emily, you mentioned the fact of investment in NIH. NIH only invests 11% in women's health, even though we're 50.5% of the US population. This $100 million investment by Biden is great, but it's a Band-Aid for the fact of the years of neglect. But it is the hope that, and a signal that you should be investing in this space. With regards to the functional roles, Blood and you put in that ecosystem. That's a very extensive view in femtech, because we're at a very early stage. Just even understanding general roles of like an investor or service provider or a researcher, and getting them to talk together with media to be able to do this has been highly important and very successful in terms of how our femtechs get investments, how they lower their CAC, which is customer acquisition costs, because they go through the community and partnerships approach, and they understand this isn't a zero-sum game. This pie is going to increase, and the only other industry, in my view, that has the same capacity right now that's heavily invested in is aerospace. And lastly, I think just being able to put in the innovation and evolutionary processes, and I think context, to be able to adjust to the short-term changes. So the rulings that we've been hearing about lately, that's a really good example that have deep impacts, but how do we manage that just from a cultural perspective? And then how do you bring that not only personally, but also professionally into the workplace? So until we build this locally, regionally, nationally, and internationally for us, I don't truly believe we have the ability to govern this space very well, because you can't govern what you don't know, but you also can't respond to what you don't see.
Good point. Definitely a good point. I think just to further on that concept is, let's talk about growth often comes with trade-offs, right? So you all three of you are CEOs of your companies. You're leading, you're trying new things. We're talking about a great array of folks here. Well, from your experience, how can femtech companies scale while staying true to their mission of innovating and making it better. And with that, I'm going to go with you, Rachel.
Well, I like to say we're in a stage of cooperation. So yes, femtechs compete against each other, but they understand that we have to work together to even increase and build out this market. And because of that, community and partnerships is key to be able to scale with less resources, being able to share tribal knowledge and access to resources as well, and being able to share and amplify each other. In addition to that is actually understanding their alternative financial tools. Financial literacy is still a key thing for us. Traditional VC investment is not the only way. And that is something that we're talking about South by Southwest is there are other ways to get to where they need to, whether it's grants, loans, maybe they want to consider M&A, crowdfunding. I mean, they just need to be aware and educated. And so those are a couple of areas for us that would help them scale for 2024 and specifically in the current climate. But, you know, given that, I would encourage people to actually invest in this space because it is pioneering, right? It's only within my lifetime, and I'm 38, that we've done clinical trials. Anything else before us, I mean, every system protocol didn't have us considered. And I think, yes, we can talk about the bad, but I think the flip side is there's a lot of money to be made as well as a lot of good to do.
Right. There's definitely a lot of progress. So we have talked about some of the gaps, but I think we are definitely on the rise here. And then I'm going to go to you, Emily.
Sure. What we're doing to kind of mitigate risk is really take a portfolio approach. We luckily are a platform of platforms when it comes to a company. And so we've looked at low-hanging fruit opportunities. We've carved out areas of interest that are high value for us. We're negotiating for licensing, like on the Intel, on the inside model, and really diversification. It has saved us over the past several years because the investor market has dried up quite a bit in the past 2 years, particularly for healthcare. And so there's ways we're staying alive and thriving by being creative and honestly coloring outside the lines.
Awesome. Aubrey?
Yeah, I would add a few things. Number one is that we get to go slow to go fast, right? Part of technology is that it's not just a single like teddy bear manufacturing machine, but we get to actually speak with patients. We get to speak with caregivers. We get to establish co-creation methodologies that at the end translate into a stickiness factor on our platforms, that translate the ability for us to show value in whatever direction that you choose to kind of sell into. The other piece is that we get to be kind of empathetic. I think the beauty of a B2B2C business model is that our users, our customers are in fact the people that empower us. And so I think that, for Femtech, to your point, like we can be seen as competitors with one another, but our differentiators are often the ability for us to establish rigorous processes in terms of co-creation, really honing in on how we actually create a differentiated experience, have that translate into the nuts and bolts of user acquisition, user retention, and then monetize that, right? The part that I would add is that traditional digital health companies might be selling into health plans or employers or others. Don't lose sight of pharma. And the reason why I say that is that we just heard from the previous panel around the elderly aging population. A lot of times that falls on women, and there are drugs out there that actually reduce fracture risk up to 41, even over 70%. And those companies want to hear information from users. And so I think that the opportunity with Femtech is to actually think really creative about business models as well that can create value not just for the companies, but also for our investors.
And you actually led right into another question I had to add. This is awesome. What advice would you give to future entrepreneurs or investors that are looking to improve and pioneer this space? I'm gonna go back down the line here, and I am throwing you off a little bit with this question, but I think it warrants. You have some great responses. I think it will really help the cause here.
Mm-hmm. Obviously, I speak to entrepreneurs first. is don't sell yourself short. Always believe in yourself. The system is set up not in your favor, and so you have to know your true north, and you might have to parallel process plan A, plan B, and plan C. I always have a plan D too. And it really is about networking and finding companies or key opinion leaders that are aligned with you. We have payers that are aligned with us. We have multiple industries, governments aligned with us. So how can we navigate the system to tell our story? And then as far as the investors go, yeah, we're a great bet. We're roll up our sleeves kind of entrepreneurs, and we know how to stretch a dollar really well. And so I think that I'm hopeful that more investors will come into the femtech area. Rachel?
So for entrepreneurs, what would I say to them? Find your moat. Find your community, people you trust, because mental health is a real thing, and it's something that we're not taught even at accelerators or anything that's formalized, let alone informal. For me, that was definitely key when I was a founder. I would say for investors, what I'm really excited about is we are in a new phase to actually explore alternative investment models versus outside the traditional VC. Since femtech wasn't made in mind when we set these business models up or investment models, I think we can go into an exploratory phase. I think there's a couple of companies like Wild out of Berlin where they got investment drastically different than anybody knew, and they were successful. And I think, again, because this is a green space, all is possible. And so I really encourage more curiosity than what people come into, well, this is how it's done and that's how it's been. It's like, but actually, we can't really do that anymore. And so I just encourage you to actually be curious and engage.
Aubrey?
Thanks. To the entrepreneurs, kill them with kindness and kill them with numbers. There's tremendous value out there. And I think that, part of our opportunity is to actually start working together, but man, is there a ton of value left out on the table. I think we heard in the panel across the hall that was talking about the payers, and nothing against any payers if you're in here, but at Rabble, we took a few years actually to really figure out what our business model is, and where we landed is that pharma, apart from any of the other Ps, patients obviously are interested, but there's a scalability issue there. Pharma has the most to lose if a patient is not self-empowered, is not asking questions. Figure out how to capitalize on that value, and man, are you going to soar. Now, again, this is US-based. I want to make a small disclaimer. There's different policies across the globe, but oftentimes money comes from pharma, and if you are really, really good at strategic partnerships, and I mean mobilizing communities and being humble enough to work with patients and learning how to work with health systems and taking advantage of implementation science, you guys get to be the digital backbone to create that meaningful change. And how rewarding is that, right? So yes, you can have your cake and eat it too. And for the investors out there, you're leaving a ton of opportunity and value on the table if you do not think critically around how femtech can create value for your portfolios.
Wow. All right, and on that note, I'd like to open it up. Does anyone have any questions that you would like to ask? Sheila? Thank you, David.
Hey, great panel. I've been working with some femtech startups myself, and one thing I think I'm learning is that, to Aubrey's point about implementation science, there's such a gap between all of these great new pharmaceutical products, care models that don't kind of translate to patient outcomes. So wondered if the panel had thoughts about that. And actually, I'm in the process of launching a new organization called the Alliance for Health Implementation Science to try to kind of harness this, but wanted to hear specifically from the panel on how they see that gap. Obviously, lots of other gaps in terms of investment and focus, but I think it's a big challenge, and in a way, a hard part of some of the new innovation is that it's led to less progress on the patient side.
I'm going to be contentious here and
Sure.
and say, look at consumer product goods because that is healthcare for women. Because the system was not made for us, a lot of entrepreneurs had to go out and create either SaaS and hardware to address those issues. And I think creatively, if you can boil down the essence or invite them on the conversation as well as the general system, you might find some innovative ways that I think are going to be revolutionary. So that's my answer.
I would just add, I think that there's tremendous opportunity for actually having research-based kind of organizations, universities, et cetera, to not only create kind of, policies and suggestions in terms of how to mobilize a market, but then partner with tech companies to actually take an objective view of, is it working, right? I think implementation science is really recognizing that just because you publish data or put policy documents out there, it doesn't actually get translated into routine practice. And we as, femtech leaders can actually help to accelerate that. But again, it's got to be in partnership with the right researchers and evidence-based kind of practices.
Thank you. Okay, well, I think we're running, are we running behind or are we good? We're good, unless there's not another question. Oh, you do, okay.
Hi, I'm Alex from Europe. The question is, when we're talking about femtech, what do you envision in fintech around artificial intelligence and machine learning? How do you see this will impact?
Well, I might be controversial right now. Okay, so we've been applying AI to biomarker discovery and multi-omics for over a decade. Nothing has really manifested. Woo, that was pretty, Nah, nothing that really comes up, because it's so personalized sometimes, and there are, okay, so let's talk about it. So most academic studies are built with male mice. Those derive data sets that are analyzed by machine learning that spit out information that can get validated in clinical studies or other animal models, right?
Okay.
When it comes to femtech, it's a whole other ballgame. Everything is brand new. And so I think that there is huge white space opportunity for folks to really dive in and investigate this. But yeah, I don't see AI coming to play for femtech in the near future.
I already have success stories related to fertility clinics, and it's femtech for sure. So yeah, maybe we need to discuss it more.
Yes, we should.
I'm going to respectfully disagree with Emily, but I think it's only because of the angle that you're taking it. So we actually had a session earlier around evolving AI and women's healthcare with FemWIC and JP Morgan, and the conversation really is about, for me, is driving towards precision healthcare. That is the ideal state, regardless of gender, regardless of anything else, precision healthcare. How does femtech get there? We need data. We need data sets. And it's not just public or government. You're talking about all the CPG companies that have to do their clinical trials and being able to consolidate them to then train that data and being able to create better, healthier, high-quality insights to drive. So for me, I'm optimistic. I think getting there is going to require, again, because we're in the unknown stage, is actually establishing the principles of how, what data do you want, how do you get it, ethically, and being able to have the right amount of diverse perspectives to help train it and be a part of that. Is going to be key for me to really, what I think the end goal is, precision healthcare ultimately.
Oh, yeah, data is the key.
It is, and I would just say it kind of depends on where you're applying the machine learning and AI associated with it. I think the exciting part for me is that a lot of times, there are barriers to care irrespective of gender, right? It can be based off of socioeconomic considerations as well as geography, et cetera. AI and machine learning I don't think we're going to change the fact that 80% of healthcare decisions are made by women. It's just kind of life, right? And so to me, it's really exciting because AI and machine learning can also be applied in the education aspect of that. And think how powerful that is, right? And so to me, I think that there's certainly the discovery aspect of AI that can benefit a lot, and there's a lot of work to do, and I completely agree with you. But when it comes down to engagement, man, is there opportunity, right? And there's opportunity in a number of different domains. And then one part that I would add is that I know that we talked about like point of care solutions. We can have point of care services and have the same platform. And I think that's a really important distinguishing factor, because we can actually start to continuously enhancing and being specific to the communities and the individual people who we're trying to serve, meanwhile collecting, to your point, kind of collecting that data and getting smarter and smarter around how we can help establish a more engaged population. So.
Yeah, thank you, but it's a big topic.
Thank you very much. Well, I just want to thank our wonderful panelists here. It's been a pleasure to actually be on the stage with you all. And you all have created your own science, right? So we have discovery science, we have ecosystem science, and we have implementation science over there. But it's more than that. So if you can all give a round of applause, that'd be awesome. Thank you so much. Thank you.
Okay. So I think we're going to just wrap up with telling you a few things about what we're doing in the US, and then it's very much open forum, so you can ask anything that you've heard already today or anything else that interests you. So with that, I'm going to hand over to John, who's just going to take us through a few of these slides. Yep.
I think you were going through these slides.
I'm going through these slides, apparently. Okay, right. So you can see the tagline, the Global Health Connector. That's who we are. That's partly what we talked about when I first opened this afternoon's session. So you can see the reach, and you've heard today a discussion about digital and data, although it was specifically on AI. You've heard about women's health, and you've heard about healthy aging. Those three themes we are taking to all of our flagship events around the world. The content for each one is different. It's not the same, but we are not letting go of those three subjects. We are pushing initiatives on healthy aging, women's health, and data and digital. So that will be a continuing theme. So as we're back at health later this year and then ViVE next year, we will be talking about these again. In terms of numbers of members, what does it look like? I'm not going to talk to those. Those are, you can read the numbers yourself. That gives you a feeling. And this is all about the multi-stakeholder approach that we have and understanding that that's a big part of our ability to have thought leadership and to lead, because it is about the ability to bring into the room all stakeholders on particular topics that are relevant. Looking at activities that we particularly want to grow and deepen, it is very much this connection with expert leaders, and I hope that from the sessions that you've sat through, we've demonstrated that. Curating best practices. So back to my point about health reinventing the wheel from place to place. Our idea is to actually promote best practices by type of condition, disease management, particular topics, and to do that in a more organized way. And then it's about our thought leadership around convening insightful meetings, whether that's virtual or physical round tables. All of that is important to us. Then we've already announced the healthy aging thematic ecosystem and its launch. And then we have another announcement to make in relation to, and I'm going to have to put my glasses on because this is not something that I'm actively involved in. So this is the African Digital Health Network, which we formed as one of the partners very recently. I said earlier on that I thought Africa was going to be very important in future years because of their first mover to digital health. This is emphasizing that the African Digital Health Network will have a commitment to foster a global collaboration in the field of digital health. It will be the epicenter of Africa's digital health communities of practice. It was made in October 2023 at the summit in Kigali in Rwanda, and it aims to empower 100,000 frontline health workers by 2030 to accelerate technology adoption and promote digital public infrastructure. There are already 50 institutions and 190 leaders signed up to it. And it's worth remembering that Africa is about, I think it's 53, 56 countries, but you can fit the entire North America, Europe, China into the size, and India into the size of the continent. So for many of us, we don't really appreciate the sheer size of the African continent.
Blessing, just to add one thing, just you mentioned demography. The whole African continent is going to go from 1.1 billion people today to 2 billion people by 2050. So 20% of the entire planet in a very young population of people. So their take, for example, on healthy aging is really interesting in terms of building infrastructure in a different way to reimagine the future. So it's really worth paying attention in both directions. Not only what are they going to come up with that we should pay attention to, but what are we doing that they could benefit from, given that enormous demographic shift.
So I'm going to end with our contact details are there. So John and Nicole are our ambassadors in the US. We want to do more and more things in the US. We have ambitious plans over the next few years about what we do. So if you want to get involved, please come and talk to us. We're all here for the next few days, but we're going to be here immediately afterwards. So with that, I'm going to thank the two ambassadors, thank all of you for coming, and I hope you enjoy the rest of the conference at ViVE. Thank you very much.
Actually, okay, this one's on. One more thing. Can you quick go two more? One more. One more. Yeah. So if you look at the breadth of what ECHAlliance offers, there's a huge network here that you can benefit from. So we actually have, if you're willing to do a little survey, this is not we're going to jump and send you a bunch of stuff. It's really just getting your input on focus groups, because we think that there's a lot of opportunity to provide that value to our members. So if you could fill that out, we'd really appreciate it. And then you can do the other one so they can be a member if they want.
Doesn't matter. We good?